the audience.
audience.
And أوقات it gets boring, especially if people who are not like into the pathophysiology thing.
Yes, I think so. It makes more sense إنه to avoid خلينا نقول التكنيكالز كتير mechanism of action. Maybe just to highlight the main points how it works, not to go deeper into these details.
Okay, all righty.
Let's see.
الإضاءة كويسة، ما في أي مشاكل في
أنا
الإضاءة.
شايفك clear وكويس. So I'm using a background, but we tried it the past couple of sessions. It didn't work for speakers. I don't know why. Maybe because I had white background وراي بالأساس يعني فيمكن مشيت معها.
بس مش حطيت اللوجو بس.
This is our brand.
Yeah, I know.
Yeah.
I think we'll wait for Dr. Muhammad because sometimes Dr. Muhammad is running a little bit.
Let me send to you.
Wallah, there is a good audience, 145 participants.
Mm, yes, indeed.
ولا بس دكتور Mr. Muad, it's already 8.
I know, but we still are not live, right?
Yes, yes.
Let's wait for Dr.
We're
Muhammad to
waiting for
join.
your
I just
signal.
sent to him.
I'm just reading your WhatsApp now. Hello, doctor. We'll start in 10 minutes. So.
Jester,
Yes, Muad.
it seems Dr. Muhammad has issues in joining. He's joining not as a panelist because he's seeing the waiting video. Can you sort this out for him?
For Dr.
Jester?
Just now. Is he using? Let me call him. Let me call him once.
Please call him, please.
أخ معاذ، أنت حاليا في الأردن ولا وين؟
Yes, دكتور في الأردن. The regional office of Stalin Greer is based in Jordan.
من زمان
من
في.
زمان، من لما بدأت في الميدل ايست أو من لما صار لها regional office let's say.
اوكي alright. كيف الجو عندكم؟
برد اليومين
شوي
هدول.
برد؟
used used to be a bit hot بس هلا اليومين هدول it's cold.
والله it's really hot here in
I know.
yesterday we had a very bad sandstorm and it was not
Yes, سمعت.
yeah.
Yes. الله يعينكم، هلا الجو بيبدأ
تغير.
يعني تطلع الحرارة شوي شوي to
لا هي
reach
طلعت
50s.
الحرارة.
طلعت وخلصت.
لا لا we reached the 40s like the mid
Yeah,
40s we reached it already so
I know.
Why? I'm
Yeah.
sorry, Dr. Ahmed. Yeah, I think Dr. Abu Zakh did not use the link for for the panelists. He joined as an attendee. Let me activate this so that I can promote him as a panelist. Okay, so that we can start. Will that be fine?
Okay.
Okay,
But
sure,
please,
sure.
right away do it,
Okay.
include him as a panelist right away.
Recording in progress. In progress. In progress. In progress. In progress.
Okay, so we have you, Dr. Muhammad, now, and I think we are live at this moment.
Can you hear me? Can you see me and hear me?
Yes, see you and hear you very well. Thank you for joining,
Right.
Dr. Muhammad.
Apologize for the delay. Good evening, معاذ. ازيك؟
It's
كيف
okay.
حالك حمد؟
الحمد
It's
لله.
Hello,
okay.
hi. Carolina, how are you keeping? Sorry, the link was sent to me as a participant, and I was trying all the tricks to try and join, but until I got Jester. So anyway, we're on board now.
Glad it worked out. So let's not further delay the attendance. Let's start. So good evening, everyone, and I am happy and glad to welcome you once again to our ongoing educational series on respiratory allergy and allergen immunotherapy. Of course, this series of webinars is organized by Stalin Greer and in collaboration with the Gulf Allergy and Clinical Immunology Society. We continue this series of webinars with the same goal as usual. It's to provide a platform for continuous learning and for expert exchange in this rapidly changing and evolving field of allergy. So whether you are for the first time with us or have been from the beginning, are glad to welcome you all. And as always, we are joined by our expert moderator now, Dr. Muhammad Abu Zaqouq, who will guide us through today's discussions and introduce our esteemed speakers. So we look forward to another successful and insightful session for all. With that, I will hand things over to you, Dr. Muhammad, to get us starting. Thank you, everyone.
Many thanks, Muad. Let me share my slides, if I may. Or do you want to share them from your end?
If you have them, I also have them. I can share them from my end.
But do I need to have a control of them if possible?
You're a panelist now. Should be able to control the slides, I guess.
Just hang on a second. So could you share them? Because as again, there's something that is not going right. So,
Can you see my slides?
yeah, I can. Yes, thank you.
Good.
Excellent. Yeah. Great stuff. So are you going to move them or do I need to move them myself?
Yes, I can move for you if you like.
Right. Okay. So are we live? Yes.
Yes, indeed.
Excellent. Assalamu alaikum and good evening, everyone. First, I'd like to thank you all for your patience. Sorry for the delay, for the slight delay. It's a computer glitch, if you like. I wasn't able to join in, so apologize. Now we're almost sorted. So I'd like to welcome you again to our allergen immunotherapy webinar series. This is a collaborative initiative between the Gulf Academy of Allergy and Clinical Immunology and Stallergeon Greer biopharmaceutical company. And really, we're very grateful for their support to spread the knowledge on this important area of therapy in allergy. Can I have the next slide, please, Maad? Okay, so this is a 6-month series that will explore various aspects of respiratory allergy and allergen immunotherapy. Again, this is an important therapeutic area that remains widely misunderstood, especially amongst non-allergists. Now, each session features national, regional, and international experts in the field of allergy and clinical immunology with discussions lasting for about 2 hours. Of course, your participation is key to the success of this meeting, so please don't hesitate to submit any questions via the chat during the talks. There'll be a dedicated Q&A session at the end of each webinar to address your queries. Okay, can I have the second slide, please? Now, brief words about the Gulf Academy of Allergy and Clinical Immunology. This was an initiative that was started back in 2022. The aim really is, can I have the next slide, please? The vision of this platform is to promote the Gulf region as a provider of state-of-the-art allergy and clinical immunology patient care, education, research, and training. Our mission and aim is to provide high-quality educational activity like the one that you're participating in now, foster collaboration amongst healthcare professionals, and promote best practices to improve patient care. Next slide, please. Now, again, we're very thankful to Stallergeon Greer, who was really the driver behind this series of educational sessions. As you all know, Stallergeon Greer is a global pharmaceutical company that is specialized in allergy diagnostics and treatment, particularly allergen immunotherapy. Over the centuries of experience in allergy, offering an end-to-end approach from cultivating allergen extracts in-house to delivering the final allergen immunotherapy products to patients across the world. Now, as I said, Allergen Immunotherapy Without Borders is a series of educational activity led by international experts on binary region allergy care. This is, of course, a regional program to deliver the latest evidence-based approach in respiratory allergy and allergen immunotherapy. And of course, you can see the list of topics to be covered in this program. We've already covered several of these topics, and this is our third session thus far. We're really proud to be part of this because the last session we had about 450 participants, staying until the end of the Q&A, which is really something we're proud of. Now, the session, as you can see there, led by several international experts in the field of allergy from across the region and beyond, from the UAE to Saudi Arabia, Jordan, Russia, Lebanon, and far and beyond, of course, and we hope to involve more experts in our next sessions. Now, can I have the next slide, Mark, please? Now, the key learning points, again, this is just a reminder of people who didn't attend the last session. So the last session was about managing patients with comorbidities, and really the key take-home message is there that the preventative benefits of allergen immunotherapy are greater if initiated early in the course of the allergic disease. And of course, a 3-year course of allergen immunotherapy reduces the likelihood that children and adolescents with allergic rhinitis driven by pollen mainly to go and develop asthma up to 2 years post allergen immunotherapy. And we had an excellent session with case representative of that in our last session. Now, the other take-home message was that related to allergen immunotherapy in children. And we've heard and learned that allergen immunotherapy may prevent the asthma onset in patients with allergic rhinitis. And of course, grass pollen allergic patients are naturally exposed, of course, and sensitized to multiple pollens from various grass species. And allergen immunotherapy with a grass mixture better represents patients with single allergen grass allergen immunotherapy. And again, patient communication is the key really for adherence, because this is really a challenge. And a lot of patients, as many of you would know, that adherence to allergen immunotherapy is a big challenge, not only in our region, but worldwide. And adherence and compliance with this form of treatment is key to the success of allergen immunotherapy. So we've heard again lots about these points in the previous session. Next slide, please, Maud. So tonight we're going to address a different aspect of allergen immunotherapy, and that is contraindication and adverse events, solutions and innovations. And these sessions delivered by 2 eminent speakers, Dr. Hamad Al-Hamli and Dr. Elena Leitsiva. Can I have a next slide, please? And so the titles of what we're going to learn about today will be navigating through the contraindication in allergen immunotherapy, identifying the risks, and ensuring that patient safety is really a priority when we offer this therapy to our patients. And then we go and talk about managing adverse events and looking at innovative strategies for safer treatment. And I'm sure all of these are important issues to address when we talk about allergen immunotherapy. And as I said, this session is going to be delivered by our 2 key speakers, Dr. Elena. Can I have the next slide, please, Ahmad? So Dr. Elena Leitsiva, she's a PhD and specialist allergologist with over 20 years of clinical experience. She's the chief of immunopathology department at the NRC Institute of Immunology in Russia. She has extensive involvement in clinical trials across phase 1 and phase 4 in allergy and immunology. She's a member of the IACI and the RAACI and many other international organizations. She focuses on immunopathology and the development of innovative allergy diagnostics and treatment. And the second speaker is Dr. Hamad Al-Hamli, who's a good friend of mine and a great colleague. He's a consultant pediatric allergy and clinical immunologist in Cleveland Clinic. Is German board certified in both pediatric allergy. Is trained in one of the famous hospitals in Germany, and that is Charité, under eminent mentors and teachers. He is the president of the allergy and clinical immunology subgroup of the Emirate Thoracic Society. Is actively involved in clinical research on food allergy, immunotherapy, and allergy prevention. Now, without further ado, I think we'll move to our first speaker, Muad.
Yes, indeed. This is the end of these slides. And our first speaker, Dr. Elena.
Dr. Elena, welcome on board. Thank you.
Thank you, Mohammed. Good evening, everyone. Thank you for joining us today in this beautiful meeting, and I'm happy to be here. And my talk will be about contradictions for this beautiful treatment. Just a second, I will manage with my technical things. Do you see my slides?
Yes, clear, we do.
Oh, sorry. So I would like to start with the words that allergen immunotherapy is the favorite tool of allergologists and immunologists all over the world, because it's the only magic that continues to work after the treatment was interrupted, because all the modern and super effective molecules we have for treatment of allergic diseases stops as soon as we interrupt the treatment, but allergen-specific immunotherapy have the disease-modifying effect. But the indication for this treatment is widely accepted, and we understand whom to treat and how to treat, but many questions arise when we talk about the contradictions for this treatment. And the contradictions may be relative or absolute. They differ from between the different kind of allergens, and they are different in between the different routes of allergen intake. Why they also, there are some argues in different guidelines, even for the same conditions and same comorbidities. Why it is so? Because unfortunately, we do not have big clinical trials that show us placebo-controlled trials in the small populations of patients with different comorbidities. So unfortunately, we're living in the evidence-based era. That's why the contradictions for each drug were formed long ago, where unfortunately we didn't have such effective but safe allergens like sublingual, and these contradictions goes back when we have only opportunity to work with sub-Q allergens, and at times the risk of anaphylaxis was much higher. We didn't understand many mechanisms of this treatment, so some contradictions are absolutely old. And now we've got some data from the publications that it is safe in different kinds of conditions. If you see the heterogeneity of the contradictions in different guidelines, have big deviations, even for the same condition. In one country it's forbidden, in one country it's a relative contradiction, but some do not have any contradictions for the same conditions. Why do not we still have this information in spite of the fact that allergen-specific immunotherapy is used for more than 100 years? Because, for example, for ethical and legal reasons, we do not have an opportunity to have clinical trials in some categories like cancer or pregnancy or too small age. That's why we do not have these informations, and we only have the observational small cohort studies and some clinical case publications that give us the information what we will have if we take such patients for this treatment. But this data, the experience, the huge amount of people receiving this treatment, and the development of more safe allergens, more safe routes, which make a risk of anaphylaxis very small. All these facts lead to the narrowing of the contradictions, and we will discuss it a bit later. So we have such a very elegant paper which compared the different contradictions, relative or absolute, from the different guidelines from the different countries, and even from the different routes of allergen intake, and even the different allergens. So you know that venom allergy stands separately from others. And even for IACI guideline, you see that the contradictions are different between different allergens and different routes of allergen intakes. About 10 years ago, IACI made task forces to bring the light on the contradictions and to analyze all the literature we have, to answer the third question on each contradiction. Actually, the contradiction, even the list of contradiction, is different in the different international or local guidelines for allergen immunotherapy, but they took the most often contradictions which you can meet in every guideline. It's asthma, autoimmune disease, malignant neoplasms, beta blockers, ACE inhibitors, monoamine oxidase inhibitors, cardiovascular disease, kids before 5 years, pregnancy, acquired immune deficiency, and other chronic disease, to and make the task forces for each of that to answer 3 main questions. The first, are there any negative effects of allergen immunotherapy on this concomitant condition or disease? The second question was, are these patients receiving Ait treatment have the risk of higher side effects of the treatment? And the third question was, do we expect the less effectiveness of the treatment if the patient have such conditions? So I would like to start with the age limitation, and I would say that actually not many kids below the 5 years need this treatment, but we see that in our practice sometimes we meet small kids which have a rather tough allergy, seasonal or other, that we want to make a decision, can we take it before they reach this age? In all guidelines, in all indications for all allergens, the age of 5 is the cutoff of make a decision to treat this patient with allergens. Why it is so? The main reason is that the next speaker will talk about anaphylaxis, but the main reason is that the patients before 5 years have a low critics for the something's go wrong. So if you know that the effectiveness of the treatment of anaphylaxis is the speed of this treatment. So in order not to miss the time when you should give the help for your patient, the 5-year-old kid can really assess his condition correctly. It's the first reason. And the second, the technical maneuver might be sometimes complicated for the small little kid. And you know that the effectiveness of the treatment depends on the dose the patient will have. So if the maneuver of sublingual intake will be done not correctly, so we will not have the good effect. But as far as we know that sublingual allergens are safe and the risk of anaphylaxis goes to 0 approximately. So we decided, I mean the medical society decided that maybe it is possible to do it with the kids before 5 years old. So what we have, there is no evidence that we have any negative effects of allergen-specific immunotherapy to the children before 5 years. There is no evidence that adverse events of these treatments are more frequent in this category of patients. And the efficacy of the treatment is not lower than in patients over 5 years if the technical maneuver is done correctly. But now the age from 0 to 2 is an absolute contradiction, but actually, usually we do not have a need to treat this patient with allergen-specific immunotherapy because of the period of looking after this baby and to prove that he had the respiratory allergies too small. So we do not need this patient to treat in most cases. But if you have the patient from 2 to 5, it's a relative contradiction. You may think that if the benefit is greater than the risk for this patient, if the patient is enough clever, I would say, to make the maneuver, so you may go to this treatment with this little kid. But given the information for his parents that you are working in the off-label field, and so all the documents must be filled correctly. The other problem, not problem, but the other side is the older patients. For a long time, there was thoughts about that if the patient is older than 50 years old, he might not have the great benefit from this treatment because his immune system may be not so reactive, or the risk of anaphylaxis and the treatment with epinephrine will do some harm for the older ones. But again, as far as we have very safe treatment which decrease the risk of anaphylaxis, so we can take this patient for the treatment. And what about immunogenicity in this group of patients? There is a very nice study of our Polish colleagues who took the not big but rather relative cohorts of patients over 65 years. They were till 73 years with the proven IgE allergy for house dust mites and pollen, and they treat them for the 5 years, and then for the during 3 years, sorry, and for the 5 years after, they were looking after them, counting the symptom score, the drug intake score, and the level of IgG for blocking IgG to understand what will be the effect of the therapy. So, of course, the efficacy was not lower. The drug intake and the symptom score was lowering. And as you see in the graph in the left part of the screen, the immune system worked correctly, and for a long period of time, they had not less than younger ones the level of IgG4. You know that IgG4 is not the marker of effectiveness of the treatment, but it is the marker that the immune system reacts correctly, even in the older patients. And of course, I'm sure that you also have the patients of older age who had a good effect of this treatment, and it is safe. So summary for the age restrictions, it's not recommended for all patients below 5 years, but if the benefits for the kid is higher than the risk, you may think about this treatment for this condition. And the upper limit is not done, so you may take any patient of any age to treat this if you proved that it's IgE allergy, and there is no other contradictions. Pregnancy is a very delicate condition, and we are always nervous if something goes wrong with the baby, and if the treatment can harm the baby. But now lots of evidence, lots of facts show us that allergen immunotherapy do not have any impact on the pregnancy itself or on the development of the baby, and even there are some trials that shows that the pregnant lady which have an exacerbation of the bronchial asthma, for example, during the pollen season, have the higher risk of the bad things that can happen with her or with the baby, with the perinatal complications, than the lady receiving the allergen immunotherapy during the pregnancy, if she do not have adverse event for this treatment. There are no data that the pregnant women are in higher risk of complications of this treatment, and there is no evidence that the effectiveness will be lower. I wouldn't persuade the lady to make the treatment during the pregnancy, but if the lady is ready to do it, is she willing to do it, is she have no adverse event during the treatment before the pregnancy, you may not stop the treatment if we are talking about sublingual immunotherapy or the maintenance dose of sub-Q. Cardiovascular disease, as far as the upper limit of the age is out, we do not have that. So of course we have some patients who have cardiovascular diseases, and when we worked only with sub-Q allergens, it was a great limitation, because if we have a need to make the epinephrine injection, it may harm the cardiovascular condition. So we were very careful, and in most guidelines it was the contradiction. But now, talking about sublingual allergens, when we do not think we'll need the epinephrine injection, we are more brave to take such patients. And the literature data shows us that cardiovascular disease itself doesn't bring the high risk of the adverse events during the allergic immunotherapy. There is no evidence that allergen immunotherapy may influence the course of the cardiovascular disease. And there is no evidence that it is less effective in this group of patients. What about the treatment with venom allergen? You know that we do not have sublingual venom allergen, and this treatment is the most tricky. The higher rates of anaphylaxis in this treatment, but if we take the patient with a cardiovascular disease who was attacked by the wasp or the bee outside, and he has anaphylaxis outside on the street, the chance to save him with a cardiovascular disease will be much more low than you do the allergen immunotherapy in the hospital, when you can monitor the patient very careful. So I would say the cardiovascular disease is the relative contradiction for sub-Q allergen immunotherapy, but not a contradiction for sublingual immunotherapy, and it's not a contradiction for sub-Q if we're talking about venom allergy. ICE inhibitors is the drugs that are widespread in the population, and is the first line of the therapy of cardiovascular disease and hypertension. And also, of course, there was some worries about how the patient will behave itself if the anaphylaxis appears. So ACE inhibitors interfering in the renin-angiotensin aldosterone system may make the anaphylaxis more severe. So if we're talking about sub-Q allergens, we should be careful. But if we're talking about sublingual immunotherapy, again, thinking that the risk of anaphylaxis and severe case of it going to zero, it's not a contradiction. So we'll take this patient for sublingual immunotherapy. ACE inhibitors do not make the adverse events of allergen-specific immunotherapy higher, and they do not interfere on the efficacy, but there are some nuances with the venom immunotherapy. It's better to change the drug during the treatment and escape using them during the treatment with venom allergy. Beta blockers, also, it's the drug which was the limitation thing for the sub-Q therapy, because if anaphylaxis appears, the dose of epinephrine that we need for correcting this condition will be several times higher. And that's why it was tricky. And if the patient couldn't stop to take the beta blockers, and we had only opportunity to work with subcutaneous allergy, we didn't took this patient. But now, having sublingual immunotherapy, we know that beta blockers do not make the risk of anaphylaxis higher. They do not interfere in the effectiveness of the allergen immunotherapy, but the risk of uncontrolled anaphylaxis is very high. So if we're talking about these patients, we will take them. If we cannot stop beta blockers, we will better take them for sublingual immunotherapy. Again, the different contradictions for venom immunotherapy, because again, if the patient taking beta blockers will have anaphylaxis after he met the wasp or the bee outside, it's very difficult to save him because time is very short for help, and outside without any doctors, anesthesiologists, it is a very tricky thing. But if you're doing the allergen immunotherapy with venom allergen with a high risk of anaphylaxis, but in the hospital under the careful monitoring of the things, it's more safe for the patient. What about asthma? Of course, allergen immunotherapy is the main tool of treating atopic asthma. But for a long time, severe asthma and uncontrolled asthma or partly controlled asthma was a contradiction for the allergen immunotherapy, because the risk of the adverse events of the exacerbation of asthma and for the anaphylaxis of the patient with the uncontrolled asthma with sub-Q allergens was rather high. But now we know that if we're working with sublingual allergen immunotherapy, the risk of anaphylaxis is very low, approximately zero. So if we're talking, for example, for these patients with partly controlled asthma, it's not a contradiction, because if the treatment do not allow you to have a good total control over the symptoms of the patient of bronchial asthma, you can add sublingual immunotherapy with halosdasmide, for example, and this will be additive effect, and the patient will get to that control. There are lots of trials now going on for adding allergen immunotherapy for the patients receiving monoclonal antibodies for the treatment of asthma, and maybe it will give us the chance to stop the monoclonal antibodies when the disease-modifying effect will be reached with the help of allergen immunotherapy. So now asthma is relative contradictions, and uncontrolled asthma is a contradiction for sub-Q allergens, and not a contradiction if it's a partly controlled asthma for sub-Q immunotherapy. Autoimmune disease is a very difficult thing, because the heterogeneity among the autoimmune disorders is very high. So in one hand, we have autoimmune thyroiditis, and on the other hand, we have, for example, lupus. And it's very difficult to make all the things the same for such different conditions. But now we get the understanding of the pattern mechanisms of allergen-specific immunotherapy, and all our fears and worries about the thing that allergen immunotherapy can interfere the course of autoimmune disease broke down. So we now know that allergen immunotherapy do not interrupt in the course of autoimmune disease. There are some cases, some publications that autoimmune disease have a debut during the allergen immunotherapy, but you know, for 100 people receiving this treatment, and not hundreds, thousands of people receiving this treatment for a long period of time, you know that allergen immunotherapy is the treatment for 3-5 years protocol. So of course, two conditions may meet each other in one point, and sometimes it happens. If it does, we stop the treatment and look for the patients and consult him with a rheumatologist. But the evidence that we can interfere in that is out, because there was a very nice trial when they took a big amount of patients and to look for autoimmune markers, and they didn't found the increasing of them during the years of allergen immunotherapy. So we have no evidence that we can interfere in the course of autoimmune disease. There is no evidence that this group of patients have a higher risk of side effects, and there are no evidence that autoimmune disease itself may make the treatment less effective. But the treatment that patients receive for this autoimmune disease to reach the control may affect the treatment, because usually it's immunosuppressive treatment. So you should look at the patient and answer the question, if the benefit and risk, what the concomitant medication he received, is the disease control or not, and make a decision. Because sometimes, for example, for several diseases, the not stable asthma or other problems can make the autoimmune disease not stable. So if you see and feel this balance, you may take this patient after the consultation with the rheumatologist and treating this patient together. The main question which rises usually from our colleagues is, can we take these patients with autoimmune thyroiditis? And we would say yes. The experience is very huge. If the patient is controlled, if the hormones are in the good level, if the endocrinologists say that the patient is stable, yes, this patient can receive the allergen immunotherapy. Endocrinologist couldn't tell you, can you do your treatment or not? He can just tell you if the patient is stable. And if it is stable, you may take this patient for the treatment. Malignant neoplasias. Because of the thing that the treatment of these conditions make great success and the patients live longer, there are lots of patients coming to us with the symptoms of allergy after receiving the treatment for malignant disease, looking for that for allergologic help. And now the data which we have from publications, from the cohort studies and the clinical cases show us that allergen immunotherapy do not interfere into the course of malignancy. Usually it doesn't influence, malignancy can no influence in the effectiveness of the treatment, and our treatment do not interfere in the treatment the patient received for the malignancy. But it's still a contradiction for respiratory allergens. Usually that should live some time, usually it's 5 years, and if it's okay, is the oncologist tell you that the patient got rid of his malignancy, you may take this patient for the treatment of allergen-specific immunotherapy. But again, the things with venom allergy is separate. And if the patient had anaphylaxis after the wasp or bee venom contact, the neoplasms is not a contradiction, because the risk to die after the meeting of the wasp or the bee is higher than the risk of the interfering of allergen immunotherapy into the course of the malignancy. Acquired immunodeficiency. So several years ago, we didn't think that we will meet these patients in our hands for the treatment of respiratory allergy with allergen immunotherapy, because the main disease is much more severe and so on. But now, after the antiviral, very effective treatment was implicated. Also, the patient has long and high quality life, and they do suffer from pollinosis, from asthma and allergic rhinitis, and they come to allergologists. Can you take this patient or not? Although there are limited evidence, that we have no evidence of allergen immunotherapy into HIV infection, a close monitoring should be done for 3 months after the treatment started. The HIV is not increasing adverse events of allergic immunotherapy, and these patients do not have less effectiveness of the treatment. We also have in our hands a few patients with HIV infection. They do well with allergen-specific immunotherapy for the whole protocol of 3, some of them 3, some of them 5 years, and the effectiveness is not lower, but these patients should be monitored more correctly. Psychiatric and mental disorders for a long time was an absolute contradiction for the treatment of allergen-specific immunotherapy, and it's the same situation as with the small kids, because the critic for the feeling is very low. It's the first problem, and so the patient will not recognize the first symptoms of anaphylaxis, and we may be late with our help. And the second is the difficulties with the sublingual maneuvers, but now having the very safe sublingual drugs, where we do not afraid of anaphylaxis, we can take such patients for the treatment if there is the third person, the parent or the tutor, who is ready to make this treatment for him, who can have some tricks to make this patient have 2 minutes having this drug under the tongue. But you should give the information for the tutor or the parent that the main thing that you must do, you must give the correct dose for this patient. So if you can do the maneuver, you may take this patient for allergen-specific immunotherapy. And again, the other situation with venom allergy, even though this treatment with venom allergen is a very high risk of anaphylaxis, it's more safe for this patient to do it in the clinic or in the hospital than to help him outside if he met the wasp or the bee. What about other chronic infections, hepatitis and others? If the infection is controlled, if the treatment is correct, you may take this patient if the benefit for him is higher than the risk. Sarcoidosis, it's not a contradiction, but you should mention and pay attention for the patient that injection may lead for the granuloma. So it's better to take this patient for sublingual immunotherapy. Primary immunodeficiency. Also, the heterogeneity in this condition is very high. We have more than 500 forms of primary immunodeficiency, and all they are different. But for the most of them, we do not need immunotherapy because they do not have IgE-specific diseases. And the treatment, if they do, will not be effective because they have the compromised antibody synthesis. But if we're talking about hereditary angioedema or about selective IgA deficiency, this tool may be used and very effective, and there's no risk for the patient. And for example, for the patient with selective IgA deficiency, it might be the tool to make this patient have less viral infection, because the barrier of the nasal mucosa will be better if the allergic inflammation is controlled. And immunosuppressive therapy, in many cases, it will make the treatment less effective. So it's the relative contradiction. If we are talking for monoclonal antibodies, sometimes we use them to make the risk of anaphylaxis less. For example, anti-IgE antibodies used in the venom allergy to reduce the risk of anaphylaxis during the treatment. Other antibodies which are widely used, like dupilumab or benralizumab, we are getting this information. There are not much of that, but soon we'll get it and talk about it again. Monoamine oxidase inhibitors, it's the drugs for treatment mental diseases. Usually we can change the medication. The problem with this medication is opposite from beta blockers. So these inhibitors, if you use epinephrine, they stop the degradation of epinephrine, and you will have the very severe hypertension. So that's why if we are talking with sub-Q immunotherapy, we will not take this patient because the risk of anaphylaxis is high. But if we need to take this patient and we cannot stop this medication for him, we can use sublingual immunotherapy, because we do not have any evidence that our treatment interfere in this drug, and no evidence that this drug make the risk of adverse event of allergen immunotherapy higher, and there is no evidence that it's less effective. If you have the patient that you want to take, but you have the relative contradictions, we can use this beautiful paper, which was published after this analysis of all the literature we have. We must tell our patients that we are working on the field of off-label, but explaining what benefit the patient will have. If you are ready to take this for yourself, to go with your patients in that, you may do that if you fix the informed consent and all the documents that make it legal. You can use it. And talking about the contradictions, you see that this great list of contradictions became very short, and most of these contradictions are temporary, because kids are growing, malignancy goes out with the treatment, pregnancy is also a short period of time. Actually, we have two contradictions. Absolutely is uncontrolled asthma, but it's also temporal usually, and AIDS. Sorry. And the last slide will be about that we have some limitations with different routes of allergen intake. For sub-Q, we do not take the patients with a high risk of anaphylaxis or high risk of comorbidities. They will have problems with the epinephrine injection. And limitation for sub-Q or sublingual therapy is the problems with oral mucosa, also erosions or implants, which the patient is planning to do. Now we have safe tools to change if we have some contradictions for the other. So this is the finish of my talk. I will say that the list of contradictions is very narrow. The most contradictions are temporal. Today, the evidence-based data are limited, but we are gathering them. And the final decision will be made by the doctor and the patients, talking about all the things we were talking today, and taking the risks and the benefits to make this decision. Thank you very much. I will be happy to answer the question at the end of the meeting.
Many thanks, Elena. That's really very informative. Great. and concise and short and sweet and to the point. We'll take the questions at the end of the session. I'm very grateful to our 300 plus participants, and I'm sure they've learned a lot from your talk. So please make sure that your questions go through the chat box to answer them at the end of the session. Now, it's a pleasure to bring on Dr. Hamad Al-Hamli, who's going to talk to us about how to deal with the adverse effects of allergy immunotherapy. So, Dr. Hamad,
Thank
the floor
you.
is yours.
Okay, I'm just trying to figure out. Okay, so thank you, Dr. Mohammed, for the kind introduction, and also thank you, Dr. Elena, for the great presentation. So today I'll be talking about managing adverse event in AIT, and I hope that you are able to see my slides.
Yes, we do. And we
Okay.
can hear you well as well. Thank you.
Okay, so I will start now. So first I will start with this slide. So immunotherapy consists of administration, as we all know, administration of repeated doses of allergen that induce immunological changes leading to production of antibodies that block the interaction of allergen with IgE. This will inhibit the release of pro-inflammatory mediator. The difference between like sensitization and like inducing immune tolerance. So basically, whenever we are exposed to low doses of allergen over the time, this will lead to loss of tolerance and the induction of sensitization. This is how we get the allergy. But when we have like the exposure in high doses of allergen, which induce local and systemic immune tolerance over the time. So the research and clinical trial over the past few decades have elucidated the mechanism of underlying immunotherapy by induced tolerance involving in the reduction of allergen-specific type 2 cell and the induction of regulatory T and B cell and the production of IgG and IgA, which blocking antibodies. So as we all know that allergy immunotherapy is associated with local and systemic reaction. Occurrence and severity of the such event may vary according to the patient allergic disease, route of administration, the dose of administrated dose of immunotherapy, the treatment regime, and but however, like it's appear within the first, these symptoms usually appears in the first hours of the treatment of administration, and usually they disappear within days and weeks. With the SCIT, which is the subcutaneous immunotherapy, the most common adverse reaction are mild and moderate local reaction at the injection site. So patient will have like erythema or pruritus on the or swelling in the injection site. While with the sublingual immunotherapy, the most common adverse reaction are consistent with mild application site reaction. Patient will have like oral pruritus or edema in the mouth or throat irritation. It's very important that to know that severe systemic reaction can occur with both subcutaneous immunotherapy and SLIT, but it is less likely and very rarely happen with the SLIT. So it is less common with the sublingual immunotherapy. So here is like we will comparing the data between the subcutaneous immunotherapy and the SLIT. We, as you can see here in the first part of the slide, the subcutaneous immunotherapy, like historically and earlier method of immunotherapy, it's been used over 100 of years, and the systemic reaction have been described in only 2% of the patient. There have been reports of fatal and near fatal outcomes. This is a study that showed by Bernstein that showed that the incident of very severe allergic reaction with fatal outcome with SCIT was 1 case per 2 to 2.5 million injection, and moderate to severe systemic reaction happened in 1 to 200 chance per injection. And frequently we see like minor or local adverse reaction. On the other hand, when we look at the sublingual immunotherapy, which is like it's more modern method and been used for the last 4 decades, and the clinical use of has been demonstrated that systemic reaction has been described extremely rare. Anaphylaxis can be described as associated with a protocol violation. In his study that showed that 11 cases of these systemic reaction were not associated with standardized slit, and also it was due to practice violation of the protocol or even overdose. Most of the time there is most of the systemic reaction is minor with local adverse reaction, and usually they are self-limited. Moderate or severe systemic reaction, usually it's less than 1 per 500 chances over 3 years. So it is less than SCAT. So it is very important to know that immunotherapy for respiratory allergy is safe. And as I showed you here, that this sublingual immunotherapy has better safety profile and low number of systemic reaction was observed during the real clinical practice. So as you can see here, like the human tissue which contain low number of pro-inflammatory mast cells and eosinophil. Mast cells are closely to the mucosal surface in lingual tissue than in other oral tissue. This may explain why one of the frequent reported slit adverse reaction is lingual edema. Nonetheless, the physiology of oral immune response implies that the most of allergen in contact with the upper layers of oral mucosa tissue is captured and processed within 30 to 60 minutes by the tolerogenic dendritic cells before it's reached to the pro-inflammatory mediator and mast cells or eosinophil. In contrast, with the subcutaneous injection, the route is usually associated with greater risk of direct contact between the allergen and the circulating pro-inflammatory basophils and type 2 lymphocyte. Additionally, the allergen likely to be captured by myeloid or plasmastocyte dendritic cells, whose effector immune response are associated with the release of pro-inflammatory mediator. Again, this graph is showing like the sublingual allergen uptake. As you can see here, it's when the slit has a better safety profile. This is possibly because of oral antigen presenting cell, mostly Langerhans and myeloid dendritic cell exhibit a tolerogenic phenotype despite consistent exposure to danger signal from food and microbes. This reduced the induction of pro-inflammatory immune response, leading to systemic allergic reaction. Oral tissue contain relatively less or fewer mast cell and eosinophil, and mostly located in the submucosal area. And in the comparison with the subcutaneous tissue, are less likely to give rise of anaphylactic reaction. Slit is usually associated with immune response that include the induction of circulating allergen type 1 and regulatory CD4 and T cell, leading to clinical tolerance. Although 40 to 75% of patients receiving slit experiencing mild and transient local reaction in the oral mucosa, these primary reaction rarely needs any dose reduction or any treatment interruption. This year, this graph will show the clinical efficacy of slit and skit in comparative studies. As you can see here, like the efficacy of the slit and the skit, it is the efficacy is almost equal, and in one study that the slit has showed more efficacy than the skit. But in general, like the slit and the skit, there is no difference in the efficacy. They work, both of them, very well with the patient and reduce the symptoms. And this is also another graph that shows the clinical efficacy of SLIT and SCIT. They are both of them like the work in reducing the symptoms score, and also they also show that they reduce the need of medication. So both of these treatments, they are very effective in treating of these allergy diseases. Again, so this is also like from the IACI and the American Academy of Allergy and Clinical Immunology. So there is they were showing the efficacy of the SCIT and the SLIT, where they examine numerous double-blind placebo-controlled study that have also confirmed the comparable efficacy between the SCIT and the SLIT. So as you can see here, the efficacy is the same in the SCIT and the SLIT population. It doesn't matter if it's like adult or children. The efficacy is also comparable with each other. But what is really important that these slide these studies have showed that SCIT induced adverse reaction can be local or systematic, and the severity of SCIT-induced systemic reaction range from mild to life-threatening. On the other hand, the sublingual immunotherapy has a better safety profile than the SCIT, and also the advantage of the SLIT over the SCIT, that the medication of the SLIT can be given at home, and only the first dose should be given in the hospital, and then the rest can be given in the comfort of the patient home. Also, this is a meta-analysis of 60 studies that shows that show also the safety of the SLIT. This is all these studies that showed no of these studies have showed report any serious systemic reaction or anaphylaxis or use of epinephrine in this episode. So all of these like reaction were very mild and were very tolerable, and they did not need like a systematic treatment with epinephrine or leading to systemic reaction or anaphylaxis. Again, this is here also a 20 controlled study that showed the safety of SLIT in asthma. So in these 20 randomized controlled treatment trial, they were comprised of 1,501 patients with asthma, and as you can see here, there were no severe adverse reaction, only one mild local reaction with itching and erythema and swelling of the oral cavity, and adverse reaction were noted. So most of these symptoms, like as this graph shows, that most of these symptoms are local reaction and they are not really severe reaction. Again, this is another slide that shows the efficacy and the difference between the Staloral and the SCIT. So it's comparing both medication, like the both method, the Staloral, which is a sublingual immunotherapy, and the SCIT. So there was most of these studies have showed that there is no significant difference in the clinical improvement. So the efficacy is the same. And for example, on the first one, it shows that the SLIT is less expensive because, as you know, that the sublingual immunotherapy can be given at home, and patient does not need to go to the hospital to receive the treatment. So there is also like a reduction in the cost and improving of the benefit of the patient. Again, when we talk about the efficacy of the medication, all of them are same from the efficacy, but when we talk about the SLIT, it has like a better safety profile and also more tolerable than the SCIT treatment. So the SLIT format, what is the benefit, the additional benefit of the SLIT? So as we all know by now that it have high efficacy and the same as the skit. And the high efficacy is due to the possible of achieving very high course of the dose of allergen, and it has good tolerability of the therapeutic dose of allergen, since there are a few pro-inflammatory cells in the tissue of the oral cavity, as I showed you earlier on the slide of the oral mucosa. And also it is one of the additional benefit, which is very important. We always talk worry about the risk and the side effect. With the slit has low risk of serious systemic reaction and anaphylactic reaction when it is in comparison with the subcutaneous immunotherapy. And also with the slit, there is no risk of transferring of life-threatening infection. I know that now this is not really very applicable, since we use we use like hygiene, like more hygiene, and we use like single use like injection. So this is like already been like reduced. And one of the important benefit of using the slit over the skit is saving time, because the patient doesn't need to go to the hospital every time he need to apply the treatment. He can administrate it at home when we go on the maintenance dose. And there is an additional benefit, which is like saving, cost saving, due to the small number of visits to the clinic, and also the adherence to the treatment. Usually it's higher in the slit, because of the treatment is due to the safety profile and the comfortable of the use of the medication. So when we talk about adverse reaction with AIT, AIT is the introduction of causative allergen in the patient body, and the occurrence of adverse reaction cannot be excluded. The adverse reaction can be both local, occurring in the site of the immunotherapy application, for example, in the skit in the injection site, and with the slit in the sublingual area, or gastrointestinal tract with the slit. Systemic reaction can happen like outside the area of allergen administration. So what are the sign of the local reaction? Usually it happen early, so usually it occur between 20 to 30 minutes from the administration of the dose. Late reaction can happen for in more than 30 minutes from administrating the dose. There is a big difference between the form of immunotherapy. As we know, there is the slit, which is the sublingual immunotherapy. In the sublingual immunotherapy, usually the symptoms vary from itching in the oral cavity, dryness, or increased salivation, or discomfort swallowing, swelling in the oral cavity. And with the gastrointestinal reaction, sometimes the patient will have abdominal pain or nausea or diarrhea. Those are the symptoms that happen may occur with the slit. On the other hand, with the skit, the local reaction can be redness or itching or of the skin, or even swelling of the inject site. And severe local reaction are not predictor of the development of systematic reaction. So we always need to be very vigilant and monitor the patient after giving the dose. So what are the systemic reaction? So usually are the same with the systemic reaction. It's the same with different form of the immunotherapy. So it is the same with the skit and the slit. Usually it's characterized by generalized manifestation of symptoms that occur outside of the area of the immunotherapy application, and usually can begin within a few minutes after taking the medication or the injection of the drug, and rarely within 30 to 40 minutes. And usually the systemic reaction, they require pharmacological intervention. So the following systemic reaction may occur, like, for example, rhinoconjunctivitis, rhinitis, asthma, or urticaria. But again, in extreme rare cases, generalized urticaria, angioedema, including laryngoedema, severe asthma attack, anaphylactic shock, are also possible, which require discontinuation of the immunotherapy. If you look at the adverse reaction with AIT, this is based on the classification of IACI. So this is the classification of the severity of systemic reaction adopted by the European Academy of Allergy and Clinical Immunology. We say 0 when there is no reaction or non-specific reaction, which is probably not mediated by IgE, like patient will have discomfort, headache, joint pain, etc. Mild systemic reaction, usually it is localized urticaria or rhinitis or mild bronchospasm, which is very important that it is decreased in peak expiratory flow, no more than 20%. Moderate systemic reaction, it can come slowly and usually comes like more than 15 minutes and usually developing urticaria, bronchospasm. But at this time, and in this moderate systemic reaction, usually we see decrease of the peak expiratory flow by not more than 40%. Severe but not life-threatening reaction. It happened very rapid in less than 15 minutes, and usually it's development of generalized urticaria or bronchospasm and decrease of peak expiratory flow by more than 40%. Anaphylactic shock, which is again it's a drop in blood pressure. Like the symptoms can vary from drop in the blood pressure, immediately developing hyperemia of the skin, itching, generalized urticaria, bronchospasm, stridor, breathing, and cause angioedema of the larynx. So what are the algorithm for of action that we need to do for local reaction during skit? So usually with a minor local reaction, when we like measure like the duration of the swelling, if it's less than 5 centimeter in adult and less than 3 centimeter in children, usually we can apply like cold compression on the site of the injection, and we then if this does not like escalate or increase, then we can continue with the skit without any changes of the dose. In case of severe local reaction, where we have like increase of the swelling more than 5 centimeter in diameter in adult or more than 3 centimeter in children, usually we give oral antihistamine, and sometimes we can give oral corticosteroid for 2 to 3 days after the injection. And usually if like this is happening during the initiating phase, we repeat the previous dose, then continue with the build-up. But if this happened like this severe local reaction happened during the maintenance phase, we administrate half the dose. With the next visit, we administrate only half the dose and of the full dose at the next visit, and then we see how the patient will react. So this is the algorithm of action of local reaction during slit. So the first part, which I just mentioned earlier, it was for the skit, and now with the slit. So for mild to moderate local reaction that have appeared for the first time and symptoms that have resolved on their own, without any medical intervention, we continue the treatment without changing the regimen, or return to the previous well-tolerated dose and continue gradually increasing the dose. In case of severe local reaction, we give the oral antihistamine and also the corticosteroid. We need to stop taking the medication for 40 hours. If after 48 hours the condition has significantly improved, we resume taking the drug. We reduce the dose by half compared to the last dose, which has caused the reaction, and then we increase gradually. So this is also the algorithm that shows what should we do, like the action to be taken in case of systemic reaction. So for mild to moderate systemic reaction, we give the oral antihistamine, and we can give symptomatic treatment. For example, in presence of bronchospasm, we can give beta-2 agonist or corticosteroid orally. And we need to keep in mind like use of local corticosteroid, like a topical corticosteroid and antihistamine is ineffective. So in case of mild to moderate systemic reaction with the sublingual immunotherapy, we need to stop taking the drug within 48 hours. If after 48 hours the condition has significantly improved, we resume taking the drug. What we do, we reduce the dose by half compared to the last dose, which has caused the allergic reaction, and then we continue increasing. In case of systemic reaction with the subcutaneous immunotherapy, if it happened during the initiation phase, we need to go back 1 to 2 steps according to the scheme that we have, then continue with the buildup of the dose. If the reaction of the mild to moderate systemic reaction occurred during the maintenance phase, we need to reduce the dose by 20 to 40% for mild severity reaction, and by 2 times for moderate severe reaction. Then we of the previous dose, and then after that we can continue to increase slowly. So what about severe systemic reaction in case, like, for example, anaphylactic reaction? So we give EpiPen, as we all know by now, like when we look at the IACI guideline for anaphylaxis or the WOW, the epinephrine is like the main drug that we use for anaphylactic reaction, and we can also use systemic steroid and antihistamine. And also beta-2 antagonist based on the symptoms. So in case of severe reaction with systemic reaction with the sublingual immunotherapy, we stop taking the drug within 48 hours. If there is no improvement after 48 hours, further analysis and possible causes of the symptoms. So we need to make sure that there was no violation of the protocol, patient did not accidentally increase the dose, or patient had any other symptoms, like, for example, uncontrolled asthma, or, for example, he took the medication while he was having an infection, which can be like causing a cofactor for the anaphylactic or the allergic reaction. In case of severe anaphylactic reaction in SCIT, it's we might consider replacing the subcutaneous immunotherapy with SLIT. So this is the algorithm that we use, the algorithm of action we use for like interrupting the therapy for Stalural. So when the therapy is interrupted for less than 7 days, it's recommended to resume taking the drug at the same doses at which the treatment was interrupted, and then continue with the buildup. But in case of the interruption happened for more than 7 days, then resume taking the drug with one press of the same concentration at which the treatment was interrupted, and then increase the doses according to the scheme of the immunotherapy. So start with the one and then go up till they reach the optimal dose. So what are the risk factors for development of adverse reaction during immunotherapy? So medical personnel or patient error. So for example, as we look at like at the sublingual immunotherapy from all the studies, that most of these cases happened because of violation of the protocol, or the patient has dosed himself or took higher doses, or can also be because patient have high degree of sensitization to allergy. And one also of the risk factor for development immunotherapy, especially with the subcutaneous immunotherapy, is using of a new vial. So in our hospital, we do a lot of subcutaneous immunotherapy and sublingual immunotherapy. It's very, very important to when we use a newly mixed vial for the subcutaneous immunotherapy, that we go back 1 step. And also one of the risk for adverse reaction is also exacerbation of the disease or acute infection. So if patient is having his like asthma is not really good controlled, or he having exacerbation of asthma, so will increase the risk of having adverse reaction. Or again, patient having a viral illness or like an infection or fever, this also can be serve as will increase the risk of adverse reaction during immunotherapy. So life-threatening allergic reaction, so anaphylaxis. So anaphylaxis is severe life-threatening systemic hypersensitivity reaction. Usually it's characterized by being rapid in onset with potentially life-threatening airway, breathing, or circulatory problem, and usually, or although not always, associated with skin and mucosal changes. In severe cases, anaphylaxis can be fatal, especially if patient does not have access to life-saving medication, for example, EpiPen. So although the fatality rate due to anaphylaxis remain low, the frequency of hospitalization from food or drug-induced anaphylaxis has been increased in the recent years. We all know by now that three most common causes of anaphylaxis are insect bite, like the venom. My colleague was talking a lot about venom immunotherapy in the previous presentation. The second comes the drug, and drug it is like one of the leading cause of anaphylaxis, especially in hospital. And food also is one of the most common causes of anaphylaxis, especially in younger kids. So anaphylaxis epidemiology, there is a global incident of anaphylaxis between 50 to 112 episodes per 100,000 person per year. In children, the incident range between 1 to 761 per 100 person per years. Reoccurrence of reaction occurs in 26.5 to 54% of anaphylaxis patient during follow-up time from 1.5 years to 25 years. So the rate of reoccurrence of the anaphylaxis is very common in patients with the severe allergy. But the good news that the mortality is still remain low. It's estimated to 0.05 to 0.51 per million people per year for drugs, and it is also the mortality is between 0.03 to 0.32 for food, and for venom it is less. It is 0.09 to 0.13 for venom-induced anaphylaxis. So those are the main causes of anaphylaxis. So food, drugs, and venom. So what is the criteria for anaphylaxis? So one of the most important criteria, it is the acute onset of the illness. So usually it happens very quick. Happen very quick, between minutes to several hours, with stimulants involvement the skin, mucosal tissue, or both. Usually it's can involve like cause generalized hives or urticaria, pruritus, or flushing, swelling of the lip or tongue or uvula, and one of these two following condition has to be met. Respiratory compromise, example, patient will develop dyspnea or wheezing or bronchospasm or stridor, or reduce in the peak expiratory flow or hypoxia. Another cause will be another criteria will be reduce in the blood pressure, are associated with symptoms of end organ dysfunction, example, hypotonia or collapse, syncope, or incontinence. One of the other criteria is severe gastrointestinal symptoms, example, severe crampy abdominal pain, repetitive vomiting, especially after exposure to non-food allergen. And the second criteria is acute onset of hypotension or bronchospasm or laryngeal involvement after exposure to known or highly suspected allergen for the patient, and usually it happens like between minutes to several hours, even if in the absence of typical skin involvement. So like not all reaction will happen with the skin reaction. Keep this in mind. So what are the recommendations? This is the recommendation of the European Academy of Allergy and Clinical Immunology for anaphylaxis. This is the guideline which was updated in 2021. As you can see here, maybe this is a very slow, very small slide, but the first thing that we need to do, we need to assess. So the ABC, which is the airway, breathing, circulation, disability, and exposure. So if you suspect like anaphylaxis, um, uh, because of the symptoms like the acute onset, life-threatening, one of like the airway and the breathing and circulation problem. Sometimes this can happen like as we mentioned skin or mucosal involvement or severe gastrointestinal involvement. The symptoms with the airway and the breathing can vary between dysphagia, voice hoarseness, or stridor, dyspnea, tachypnea, wheezing, cyanosis. Symptoms of the blood circulation can be like a patient will get like tachycardia, hypotension, or like developing dizziness or fainting or confusion. Skin or mucosal or GI manifestation can vary from generalized pruritus, flushing, urticaria, angioedema, vomiting, abdominal pain. In case of any of these criteria, like if the criteria of the anaphylaxis is met, then the first line of treatment is to give the epinephrine or the adrenaline. Um, for the patient, if you have the auto injector, so usually the dose for the children between 25 to 30, actually it's from 15 to 30, we give the 0.15 milligram IM. In case of the patient is adult or children who are like weigh more than 25 kilos to 30, we give the 0.3 milligram IM. We need always to call for help, remove the potential trigger, optimize posture of depending on the presentation. Mainly if patient with respiratory setup with elevated legs. If mainly cardiovascular symptoms, lay patient flat and elevate the legs. Again, patient, if he's having like respiratory distress, we need to also provide high flow oxygen, 10 liter per minute with the reservoir bag. If circulation and respiratory symptoms, we should give also IV fluid with bolus for patient in case of children who's like between 25 kg to 30, we should give 10 ml per kg. And for the adult patient, we can give 500 bolus and then we repeat like the fluid if needed. In case of stridor, we can give nebulized adrenaline as supplement to the IM adrenaline, and children and adult they will 1 milligram with 4 ml of normal saline. If patients start to have wheezing, we also can give the beta-2 antagonist nebulizer, salbutamol, or we can also nebulization, or we can also give with MDI inhaler, but we need to use the spacer. Again, this is here for the adult and the school age. Like these are the doses for the salbutamol is 5 milligram for the adult and for the school children, and for the pediatric population or preschool, we give 2.5 milligram of salbutamol. In case of MDI, we give 600 microgram for adult and 400 microgram for pediatric or preschool population. If there is no improvement of the symptoms, then we can repeat the treatment. We can give the second epinephrine and give fluid as needed, and we need to make sure that circulatory or respiratory compromise despite IM. We need to call emergency and we give the treatment. We don't have to delay the treatment. If the patient needs the adrenaline, we can do it. Can give up to 2, and then if the patient have like we need to call emergency team and including critical care expertise to provide advanced treatment, including like epinephrine infusion. In case of cardiac arrest, we need to follow the guideline with doing the CRP, and we need always to monitor the patient's cerebral status, pulse oximetry, and blood pressure and ECG. So this is also the recommendation of the World Association of Allergy and of Allergy. So this is the guidelines which was published in 2020. It is similar to the one with the European Academy. So it has the same idea with where like the adrenaline should be always be given in case of suspicion of anaphylactic reaction. Also, epinephrine shouldn't be delayed. And this is also the diagram of like the discharge and management following the acute anaphylaxis episode. So we always need to make sure that the patient receive EpiPen before discharge. And the most important thing, not only to prescribe the medication, but also to explain to the patient how to use the EpiPen. I have seen in my clinic that patient who comes to my clinic who have history of severe anaphylactic reaction to food, and when I tell them like, okay, so how do you use the EpiPen? Some of them they don't know how to use it. So really, like training the patient on how to use EpiPen is very important. One of also the recommendation is also to medical identification. So patient will have like a label that what he's allergic to, like for example, like hand bracelet, where or like sometimes of the patient will have the card where he have like the written his treatment and the list of allergen. One of the most thing that we do, like after discharging the patient, we need to confirm the diagnosis. So we do like in the allergy testing, we do like either skin testing or like a specific IgE in serum to confirm the diagnosis of allergy, to identify the trigger of his symptoms, and then lastly, we need to make sure that patient is avoiding these allergen, and in case of these allergen can be treated, like for example with immunotherapy. Like for now, like we do have a lot of patients who have oral immunotherapy for food, and in case of venom, we can also do the subcutaneous immunotherapy for venom. So these need to be addressed and also addressed with the patient and discussed. And for each patient will have a different plan based on the trigger of his anaphylactic reaction. So if you look here, this is a checklist to do like during the acute allergic reaction. You always have to stay with the patient. This is number one. Then the second thing, we need to identify to remove the trigger. So if it's a food or drug or venoms, you need to remove the trigger. You always need to be vigilant and look for any sign of anaphylaxis. In case of anaphylaxis reaction, administrate the epinephrine. And also you need to address the other issues like the breathing issue or the circulatory problem. Always call for help. Keep the patient on flat with their leg raised unless respiratory distress, where patient may prefer to be set up with elevated leg. In case if you give the epinephrine and there is no improvement of the symptoms, you can go ahead and give the second dose of epinephrine in 5 to 10 minutes after administering the first dose. Always keep in mind, don't forget the oxygen and the beta 2 agonist inhalation, and also the IV fluid. And remember that and keep this in mind that epinephrine is effective to all symptoms of anaphylaxis. And here I come to the end of my my topic. So these are the key things that, or the take-home message that you need to keep in mind. Efficacy of immunotherapy. Immunotherapy has been shown effective in treating allergic rhinitis and or asthma and specific food allergy by reducing symptoms and medication use. SLIT and SCIT demonstrate comparable high efficacy and safety of profile of AIT. Overall, AIT has a good tolerability profile with mostly local administration site and mild systemic reaction occurring usually during the first weeks of treatment intake and declining over the time and with repeated treatment. Severe systemic reaction can occur, but rarely and rarely notable with SLIT. SLIT has a better safety profile over SCIT. We need to increase the awareness of the possible adverse reaction of in AIT, and their timely managed is the key to high safety and efficacy of the treatment. So again, epinephrine is like the main medication that we need to use in anaphylactic reaction. And I think I reached the end of my my talk, and I will be happy to share question with Dr. Lina from the audience.
Thank you, Dr. Hamad. Very good, very comprehensive exploration of how to deal with adverse reaction to AIT. I think we have a number of questions from the audience, but before going to the audience questions, a few comments, questions related to your topics. So first is that what are the red flags for adverse reaction to immunotherapy? So are there any sort of pointers as a clinicians when we think of allergen immunotherapy to look for to tell us that this patient is gonna really have an adverse reaction? So what are the red flags to adverse reactions in allergen immunotherapy? Either of you can answer the question. Dr. Elena, maybe I'll start with you.
With me? Okay, thank you. I would say that the main red flag is the high sensitivity for the allergens. It's the patient that we need to treat carefully because it's the high risk. Unfortunately, if we are talking of sub-Q allergen immunotherapy, the local reactions are not predictors of systemic reaction, but usually we do it also more carefully, and the intervals maybe a bit longer just to make the hand feel better. The risk is, as the Hamad brilliantly tell us, is the mistakes usually of the patient or of the doctor who is doing this. I would say, I think that sometimes when we're talking about security, it's also the diet, maybe. If the patient is not compliant and don't listen to you.
And may I add something? Also, like one of the some of the red flags, like also like if patient, like for example, in case of asthmatic patient and patient he's not compliant with medication and his symptoms is not controlled, this is like also might cause like increase the risk of having adverse reaction. Another thing, like sometimes we see patient coming out in our clinic, they have like flu symptoms or fever, and they said, oh no, it's fine, I just like have a fever, but I took and like some medication like antipyretic medication. Again, like an active viral illness or infection can also like increase the risk of of developing allergic reaction or adverse reaction.
Right. Yeah, I think that's really correct in terms of maybe uncontrolled asthma is another high sensitivity. Now I've been doing allergen immunotherapy for years, and I don't think there is an absolute contraindication to allergen immunotherapy. The only contraindication to me is non-compliance. So from the beginning, I would discuss with patients whether they are going to be compliant with this form of treatment, because it's really a long journey, and if the patient is not compliant with their therapy, it's a waste of resources, a waste of time, and I'm not really entertaining any patients who are not really compliant with them. So the only contraindication to me to immunotherapy or allergen immunotherapy is non-compliance, and there again, the red flag is non-compliance with their other medications. So, and that give me, indications that this patient, okay, they're not able to comply with their inhaler or their nasal spray. How would they gonna stick with a tablet or with subcutaneous allergen immunotherapy for 3 years at least? So this is an important issue. So compliance judging your patients, or having a sort of an open conversation with your patients about compliance, because we're suffering from this in our region, and I think less. I've seen less of it in Europe, for example, where I used to practice. Elena, do you have any experience with that? How is your
Yes,
patient?
of course, I absolutely agree. For me, it's the main problem. I will not take the patient if I see that he will not be compliant.
Right. Dr. Hamad, what some practices prescribe an EpiPen routinely to all patients on SCIT. How would you see that?
With SCIT, yes. I think every patient with SCIT treatment, he need to be like given epinephrine. Because sometimes like we had like some incident like where a patient while you're doing well, and then like he left the clinic while he's going to in the parking lot, he started to have like severe allergic reaction. So the problem with this, like we don't see it that much with the slit, with the sublingual immunotherapy, because it's have higher safety profile. But in case of the SCIT, as you know, that every time, especially like in the build-up phase, we usually increase the dose like every time we see the patient. So every time there's like an increased risk of like allergic reaction. So EpiPen should be like in a handy with the patient all the time.
Do you mean that you would give it to every patient's starting SCIT, even those with allergic rhinitis? So if a
Yes.
patient with allergic rhinitis is starting SCIT, do you give them an EpiPen or an epinephrine?
Yes, I will do.
Then there'll be no epinephrine auto-injectors. This is a very costly business. I probably would disagree with you, because I would only prescribe EpiPen. It has to be done on patient needs basis, rather than just give it to everyone, because I think patients with allergic rhinitis or who I'm offering allergen immunotherapy, it's not a routine practice to provide them with an EpiPen. So I would be probably more in those patients with severe asthma who I'm offering an EpiPen or offering allergen immunotherapy, but not a blanket. I wouldn't offer it to everybody. What about you, Elena? What do you think?
No, I usually do not also give to everyone, because usually we look after the patient about an hour after the injection. So the most severe cases are happening here in the first hour. Sometimes they do come back when they left the clinic, but they are not so severe. Usually we don't need for them. But sometimes, of course, for some patients I will.
Right. Excellent. What about you've spoken about the for slit? What are the incidents of EOE? Is that something that you've seen commonly with slit eosinophilic esophagitis? I mean, what's your experience in that?
It's for me or for?
Well, either of you. Yeah, I will start with you, since I can see you beautifully on the screen here.
I don't have not many of such patients, but I do have some of them. So for this patient, I will switch to the sub-Q immunotherapy. But
Dr. Hamad.
sorry?
Dr. Hamad, what do you think?
Well, we see it more with the food. So it is, we see it more with the peanut, especially when we started the sublingual immunotherapy with peanuts, we have seen like more cases of EOE. But like, honestly, from my experience with the sublingual immunotherapy for like aeroallergene in general, I haven't seen cases, but sometimes we see some patients who develop like acid reflux, but not really EOE.
Yeah, I've seen it with a few patients with slit And certainly, it's something that needs to be, looked at some point. And so it's not common, yes, but it can happen. Okay, now back to the questions from the participants. We have about 300 participants, which is it's a great really to see such a number persevering with us until late in the evening. So the first question here is really from anonymous attendee. Any role of immunotherapy in patients with already are on biologic treatment for asthma?
I think yes, there is like a role of immunotherapy. The difference between between immunotherapy and biological treatment, once you stop the medication, everything go back to like to the patient status. So like it's not gonna change, like act as like immune modulator only for the period when the patient is taking the medication. But with immunotherapy, on the other hand, once you start the treatment and the like there is an immune modulation happened, and the effect will last forever. So it's not gonna be stopped like after completing the treatment. But again, with the biological treatment, usually it's the $1 million question: when we gonna stop the medication? Most of the time we won't, because like once if you stop the medication, everything go back to the old time.
Elena?
I just want to add that the trials are going on. If the treatment with allergic immunotherapy will give us a chance to stop the immunobiologic treatment, so we'll have more patients with controlled asthma that we can take for the treatment of allergen immunotherapy, and maybe they will have a chance to stop immunobiologic therapy as soon as the disease-modifying effect of allergic immunotherapy will start.
Yeah, the bottom line is that there is no contraindication. I think you can use both for asthmatics. One is a disease modifying. So like Dr. Hamad said, allergen immunotherapy is really a disease modifier. Well, the other one doesn't really well, you can we need to define disease modification, because some experts would disagree that biologics are not disease modifiers. But in reality, I think disease modifying is, in my view, is that it actually changes the disease behavior, if you like, or it provides a cure. I think the only medication that provides a cure from an allergy is allergen immunotherapy, in my view, or potentially provides a cure. So there's no contraindication, and you can use both. In fact, a benefit probably from the biologic, it acts quickly. So compared to the allergen immunotherapy, which may take a year, for example, in some patients before you see an effect. So yes, there's no contraindication. Both are complementing treatment, in my view. Okay, the second question from, again, anonymous attendee is it necessary to do spirometry for all patients before starting SLIT, even without any history of suggestive of asthma? Dr. Hamad.
Oh, sorry.
Or Dr. Hamad, yeah.
Dr. Not really. If your patient doesn't have asthma, why? I don't think that it's necessary for all patients. If patient never have asthma, why would they do it for every patient?
Nothing to add.
Right. Okay, good.
There is like
Anyways,
Americans say, if it's not broken, don't fix it.
right. Any issues in switching patients from one route of allergen immunotherapy to another? For example, SCIT to SLIT, or SLIT to SCIT. Any issues switching, Dr. Elena?
I think the main issue that even if you are receiving maintaining therapy, you should start from the beginning. If you switch from one route to another, that's all.
Yeah, I agree. Also, like with the SCIT, not all SCIT are created the same. So there's difference between this subcutaneous immunotherapy?
The question really is switching, but it doesn't say when to switch. I mean, switching during therapy, or switching, for example, after a patient finishes the course of allergen immunotherapy. So yes, we can switch. For example, if a patient's completed the course of the immunotherapy and then became symptomatic later on, yes, you can switch from. You can offer them. So if they received SCIT, you can switch them to SLIT or vice versa. However, if the patient is on SCIT or SLIT and develops significant side effects, then I think you need. I believe. Well, you need to switch them to another route, but you have to start from slowly and safely, so to prevent adverse effects. But there is no switching. However, you need, for example, if the patient is on maintenance dose on one route, you cannot switch him to another maintenance dose on the other route, because I think we had a significant reaction recently when a patient was switched from SLIT to SCIT, but was given SCIT at low maintenance dose. And that created an issue. So I think if you want to switch the patients from one route to another, you have to do it very carefully and safely. Okay. Another excellent question from Dr. Ala Al-Qada, I think, and it's an immunological question, which is really quite good and interesting. So allergen immunotherapy works by inducing tolerance to allergens. One important mechanism is shifting our immune response towards Th1 regulator pathway than Th2. Interferon alpha promotes this direction in elderly, where there are expected to have less interferon alpha. Do we know if the lower levels of interferon alpha can negatively impact efficacy of allergen immunotherapy? So that's one question. Could measuring interferon alpha levels before initiating allergen immunotherapy predicted efficacy? And this is from Dr. Wala, assistant professor in immunology and allergy in Jordan. Who wants to take this question?
I may start, or I may continue if you want.
Go ahead. Yes, please.
I would say that lots of brilliant brains were thinking about what predictors we can use to predict the efficacy of allergen immunotherapy. A lot of cytokines were examined, lots of other things, but unfortunately now there is no one laboratory test which will show us that the efficacy will be higher or lower. Unfortunately, the interferon alpha also, but I would rather think about interferon gamma than alpha. But still now we're looking for other predictors, for example, methylation of DNA, for example, in FOXP3 gene promoter or other regions to understand the switching to Tregs from Th2 to Th1. But unfortunately now we have no laboratory predictors.
Yep, I totally agree. I mean, we don't really know even how allergen immunotherapy works, really, to be honest. So, I think it's work in progress for the last 20 odd years, if you like. So the answer to your question, Dr. Wala, is that we don't really know, and there is no test to predict whether these patients are going to respond or how the response is going to be. Okay, so another question about medications. Do we increase the dose of all medication before starting allergen immunotherapy? Do we need to do that, Dr. Hamad, do you think?
Is it like, for example, like in case of asthmatic patients, so we need to increase the doses?
Maybe that's the question. I mean, there's no specific. He's not talking about a specific disease, but let's
Well,
take asthma
the most
an
important
example.
that the patient symptoms is controlled. That's the most important thing.
Yeah, I think I do agree with that. However, I don't think even with severe asthma is an absolute contraindication, because again, you can give biologics, and we've done that, biologics with SCIT as we've used that, and patients tolerated SCIT pretty well, actually. Dr. Elena, any
Yeah, I
comments?
agree. I totally agree.
All right. And this is for you, Dr. Hamad. In anaphylaxis, subcutaneous or IM adrenaline is superior? Which one is superior?
Well, IM.
True.
There has also been a lot of study that showing like the difference between like whether it's subcutaneous or IM in different part of the body, and the thigh was like the best location, and IM, because it was like they measure like the onset of the medication and the bioavailability, so it was better with the IM on the thigh. So they compare it with the upper arm and different part of the body, but like the thigh was the best location.
Excellent. Is exthalmosis a contraindication for slit? Dr. Elena.
I would say that the reason for this condition may be different. For example, it's not a well-controlled thyroid disease or any neoplasma of orbita or something. So you should check what's happening with the patient, and if you have some uncontrolled disease of any case, it's a contradiction, maybe temporal, but at that time it will be.
Right. So it is not a contraindication to slit.
No, I mean that exotherm itself, it's not a contraindication. But if the disease is under that uncontrolled, for example, thyroid eye disease, it's a temporal contraindication.
Yeah, I think this applies to all diseases. You wouldn't start immunotherapy or allergen immunotherapy for any active disease. Even an active infection or whatever. Although an infection is not a disease, but I wouldn't start or recommend starting allergen immunotherapy if the patient is sick and is not and have a disease is not controlled. So I totally agree with you there. But exthalmosis is not really a contraindication per se to slit, for example. Now, for the sake of time, and I'd like to finish, we're a bit late to start, but the last question here is, in patients with severe eosinophilic and allergic asthma with cat allergy in remission and well controlled, how and when you can start slit? So this is a patient with severe eosinophilic or allergic asthma with cat allergy. The asthma apparently is in control. When and how you can start slit for cat allergy?
Well, if the symptom is well controlled and he's in remission, you can start right away.
True. Dr. Elena, any other comments?
Nothing to add.
Yeah, it applies to everything. I think if everything is, if the patient has any disease, this disease has to be a remission, if you like, and the patient is well. Otherwise, you will not be able to predict how the patient reacts to the treatment. So I think you need to make sure that the patient really is in their best health before starting either slit or skit. Would you agree?
Yes.
Excellent. Okay, I think for the time we're 7 minutes past 10, so I think we'll start here. It remains to thank you all for your excellent comments, to our speakers for their state-of-the-art presentation, to Stalagen for their support and enthusiasm and dedication to education. And I'd like to extend our gratitude to the participants who we had over 300 staying with us up to this time of night and sharing part of their evening with us, learning about allergen immunotherapy. I'd also like to thank Peril for their excellent running of this series of events. And I hope to see you in the next 4 to 6 weeks for another educational webinar on allergen immunotherapy. Thank you very much indeed, and have a good evening. Thank you.
Thank you.
Thank you, everyone. Have a great night.
Bye
Thank
bye.
you.